On to Crohn's disease now. So again, Crohn's is a part of IBD, so it's still an inflammation. But in Crohn's disease, the structures of the GI tract involved can vary anywhere starting from mouth to anus. So any part of the GI tract can be involved in Crohn's disease. And the inflammation here is a transmural inflammation, that is, inflammation, and all of the layers of the gut are involved. Here, the immune system involved is T cells, whereas in ulcerative colitis, we saw that it was P ANCA. Because the T cells are involved here in Crohn's disease, it forms a granuloma, but is a non-caseating granuloma. Do you know where a caseating granuloma is formed? It is formed in tuberculosis. Because of the transmural inflammation, they can have stricture formation and fibrosis formation, which is a very known complication of Crohn's disease. In Crohn's disease, there are skip lesions, meaning not a big chunk of GI tract is involved, but a small pieces of GI tract is involved with normal mucosa, and that leads to a skip pattern. The other extra-intestinal manifestations seen in ulcerative colitis are also seen in Crohn's disease for the same reason, because it is an autoimmune pathology. Coming to investigation, fecal calprotectin is positive in both ulcerative colitis and Crohn's, and biochemical tests such as iron, B12, folate, all of these can be low as well, and there could be nutritional deficiencies in Crohn's. Inflammatory markers are raised as in ulcerative colitis. A confirmatory investigation is, in this case, in Crohn's, an endoscopy. Usually, we start with endoscopy to look for pathological lesions and take biopsy, but they might also end up having a colonoscopy and or also a sigmoidoscopy along with this, depending on where the lesions are found. Remember how we spoke about Rome criteria in IBS and True Love and Witts criteria in ulcerative colitis? Here in Crohn's disease, we have Vienna classification, which was previously done. Now it's a Montreal classification. Here, the classification is based on 1. The age of diagnosis, 2. The location where the pathology is present, which is small intestine, large intestine, or rectum. 3rd, it is the nature of the pathology, which is it stricture forming, is it non-stricture forming, or is it fistulate? In addition to these, Crohn's disease is notorious to form perianal disease and form fistulas, which needs repairing. Treatment of Crohn's disease is similar to ulcerative colitis in that, as in we give corticosteroids, 5-aminosalicylic acid, and steroid-sparing agents, and cyclosporin and infliximab if they're refractive to steroids and steroid-sparing agents. But it's important to remember that the 5-aminosalicylic acid we give here in Crohn's, the formulations are different. In Crohn's, we give Pentasa, and in ulcerative colitis, we give Octasa. It's still a 5-aminosalicylic acid agent, but according to the pH, the site of GI tract it activates or it releases differs. So in Pentasa, it starts its release from the small intestine and it spreads out while it comes to the colon. So maximum impact is in the small intestine. Whereas in Octasa, the maximum release and maximum impact is in the colon. Where the medication failed and the complications and symptoms are maximum, we would start thinking about surgery in case of Crohn's as well. Compared to ulcerative colitis, patients with Crohn's end up having surgeries early on, that is, within 20 years of diagnosis or living with Crohn's, they would end up having a surgery. You would end up having a ileostomy or a colostomy or ileoanal pouch. Anything is possible here because it involves any part of the GI tract. In ulcerative colitis and Crohn's, that is, in case of IBD, there is risk of malignancy as well, because any chronic inflammation can cause malignancy.